Let's go ahead and get started. I'm going to do a screen share of that review. All right, so let's get started with antibiotics. Someone put in the chat a thumbs up or yes, I can hear you if you can. Awesome, thanks so much. All right, so let's start with penicillins. So we're going to go through a couple of different antibiotic classes. So we'll start with penicillins. This includes things like penicillin, amoxicillin, ampicillin. These cover our gram positives, penicillin, positive P for positive. So here it's going to cover things like strep mainly. It covers a lot of strep infections, so it'd be strep pneumonia, strep pyogenes, as well as enterococcus. If you take amoxicillin and add clavulanic acid, you get something called augmentin. It covers the above, as well as some atypicals like H. influenza, E. coli, as well as different strains like Klebsiella, Proteus, Bacterias, Fragilis. It still doesn't cover MRSA, but the benefit with augmentin is many of our gram-positive bacteria have figured out how to make an extra barrier around themselves that is not sensitive to penicillins. And so if we add the clavulanic acid, it breaks down this barrier, this wall, so to speak, and allows the penicillin, the amoxicillin, then to get inside of the bacteria and do its job, which is, it's a bactericidal. It kills the cell wall and then allows the bacteria to die. So it does not cover, again, does not cover MRSA, but it has a wide range of uses. It is narrow, but it does have a wide range of uses as far as upper respiratory infections. 10% of the population do report a penicillin allergy, but it's actually less than 1% of the whole population, which is truly allergic. In the comments, put down what do you think are some of the reasons people will say they're allergic to penicillin. That isn't actually a reason that they're allergic and doesn't really require us to stop using that medication with them. While you're thinking of those, I'll go ahead and start talking about some of those reasons. Some of the main reasons I find that patients will report an allergy is that they were allergic to it while they were a child. A lot of people will grow out of that allergy as an adult, and it was a mild allergy as a child. They might have gotten a mild rash. Some people will also report it if if a family member is allergic to penicillin. So far in major studies, it doesn't seem that there is a high enough correlation within a family that if one person is allergic to penicillin, the rest of the family will be. Some people will think nausea and vomiting is an allergy. It probably just means that they need to eat some food when they take it, take probiotics or probiotic-rich foods. And lastly, and this is actually fairly common, is that children often get rashes when they have viruses. And so many children will have a viral illness, a viral upper respiratory infection, and will be inappropriately prescribed antibiotics. And at the same time, they begin to have this viral exanthem, this viral rash. And so then the rash is misattributed to the antibiotic, and it's documented then as an allergy when it is not truly an allergy. And so that definitely happens. So what should we do then? So we should take very detailed history as far as what they mean by an allergy. We can also do additional tests. We can do skin testing or challenge doses to see if they're allergic to them. This is actually a wonderful thing for us to do if we can. We are using broad spectrum antibiotics to treat things that could be treated with something more narrow, something like penicillin. And that's a strong desire. We want to have the most narrow thing that we can have. So if we have the availability and the option to do an oral penicillin class challenge with amoxicillin, that's great. We can do that in an office, in an allergy office, to rule that test, to rule that allergy out and get that taken off of their chart. So that is gold standard. We would love to be able to do that on all of our patients, but sometimes it's just not either financially possible or there's not enough resources to do that. But that is the best case scenario, especially if the patient has never had a true anaphylactic reaction and it's just a rash. What are our next class? That would be your penicillinase resistant penicillins. The medicine in this one that's primarily talked about is dicloxacillin. So in addition to the strep coverage that traditional penicillins have, this one also covers staph. It still does not cover MRSA, but it can be used for skin infections like impetigo and hidradenitis suppurativa, which is a condition that features boils in usually under the arms, sometimes under the breasts, and very often in the groin, which is caused by bacterial overgrowth and can be treated with things like dicloxacillin. So that's an additional usage for this medication. Next, the cousins to penicillins is your cephalosporins. There is several generations of medications. In the outpatient setting and in family practice, the most common classes that we'll use is the first and third generations. In the first generation, the most common medication we're going to be using there is Keflex. And in the third generation, we're going to use things like Omnicef or Rocephin. We often use Omnicef because it's got some gram-negative coverage. As we go further down the generations, we get more and more gram-negative coverage. And these are very helpful if a child is failing treatment for something like an ear infection. So they come in, they get diagnosed with an inner ear infection. They're put on amoxicillin, but 3 days later they still have pain, they still have fever, no changes. We would then want to try to change them. We want to up the coverage, so to speak. We want to get broader coverage because apparently we didn't hit the right bacteria. So we need to use something like Omnicef, which has a broader coverage. So we use Omnicef. And then we use Rocephin. It's an in-office injectable antibiotic. We use it for common bacterial infections. If someone's got a bad sinus infection with a high fever, or they've got pneumonia that's, could use a boost to start off with, so to speak, you can give them a shot of that and then continue by mouth antibiotics at home for 5 to 10 days, depending on the severity and the specific illness. We also use it for gonorrhea, pelvic inflammatory disease, and urinary tract infections. It's not a first line for a UTI, but it is definitely an option. And again, if they're febrile and have chills and things like that, we like to use an injectable versus an by mouth because it's going to work faster and stronger. So there is some cross sensitivity between cephalosporins and penicillins. It's very low, and it is typically only in the first generation with Keflex. And Keflex, we use it for skin infections that are not suspected to be MRSA. Some people will still use them for UTIs. I don't recommend that generally because the resistance rates of most of the bacteria that cause UTIs are resistant to Keflex. So I do recommend using Keflex for things like an infected spider bite or something on the skin, but not for UTIs. So there is some cross sensitivity between the first generation and penicillins. It is quite low. The studies that are commonly cited where it talks about the 10% cross sensitivity these studies were done in the 70s or 80s when cephalosporins were actually contaminated with small samples of penicillins. So of course they were going to look like they were allergic to it because they were contaminated. There is cross sensitivity, it's very low. If a patient only has a rash, you may use any cephalosporin. You may trial it. If a patient has ever had an anaphylactic reaction to a penicillin, do not use the first generation, and it is probably safest to not use any cephalosporin if they've had an anaphylactic reaction. In our next category, we're going to talk about macrolides. There are some other medications that end in mycin, but these do also end in mycin. So this is azithromycin, erythromycin, and clarithromycin. They are, again, broader spectrum. They cover your positives, your negatives, and some atypicals. We like to use azithromycin because it is very well tolerated. It has a low side effect profile. Erythromycin, which was the original medication in this drug class, it causes very severe diarrhea and GI cramping and nausea, vomiting. Mostly it's the stomach. The diarrhea is the biggest problem with the erythromycin. We don't use it by mouth anymore. We use it as an ophthalmic ointment for bacterial conjunctivitis. Azithromycin has a broad range of uses, including community-acquired pneumonia, COPD exacerbations, chlamydia, and pertussis. Again, this is also known as Z-Pak, and because it has been overused for many upper respiratory infections, either for viruses or inappropriately for maybe a mild bacterial infection, it is overused, and therefore there is a significant amount of resistance to this medication. So it isn't as effective for community-acquired pneumonia or COPD anymore. One way that I do find it quite useful is that if you use it alongside Augmentin, they work together. They can work kind of synergistically because one of the bacteria, like Augmentin, works on the cell wall, And if you've weakened the cell wall, azithromycin has a better chance of kind of working. So you get this 1-2 punch by combining those medications. So it's azithromycin alone is not very effective. Augmentin alone can work very well, but if you add azithromycin to the augmentin, it can be helpful, to my understanding. Clarithromycin is used as part of the H. pylori treatment regimen. Again, due to the overuses of azithromycin and their relative similarities between azithromycin and clarithromycin, there's actually now issues with clarithromycin as part of the H. pylori treatment regimen. So currently on boards, they still use the triple therapy, the clarithromycin, as part of that treatment algorithm. But in the upcoming changes and evidence-based guidelines, we're going to start using quadruple therapy, which uses different medications that we won't discuss today because we're going to focus on what we're studying right now. But do make sure that you're paying attention to those changes when you start practicing. Okay? Quinolones. Oh, I do not like the quinolones, the fluoxetins. I would always counsel you to use your fluoxetins only when you don't have another choice. And typically when I say you don't have another choice is the patient's got 1 foot in the hospital already, because if they're going to go to the hospital, they're likely going to be given a fluoxetine. You've hung levofloxacin as an RN many, many times on patients coming in through the ER, especially before we know what bacterial infection they have. They're septic, they're shocky, they've got really bad pneumonia. We're going to give them levofloxacin in the ER and continue it on the floor until we get a better idea of maybe what exact bacteria we're dealing with. So the patient's already basically going to be hospitalized, likely, older, comorbidities, very ill, looking a bit shocky. Starting levofloxacin in the outpatient setting is okay. Also, if they have something like prostatitis, it is incredibly difficult to get enough concentration of antibiotics in the prostate to begin to fight that infection. But the quinolones do collect well in the prostate. So we want to use fluoxetins for prostatitis. Don't use it for UTI. Don't use Cipro for UTI. There's so many better things than that. So levofloxacin I'm going to use for pneumonia, and someone who's very ill might end up in the hospital anyway. And then with Cipro, I'm going to use it maybe for prostatitis. But again, for UTI, I'm going to use other things first. It has a wide coverage, which is why it's used in the ER very often, in the hospital setting, because again, they're coming in shocky, they're coming in comorbid, they're more likely to have an atypical bacteria, something that's not going to respond to augmentin alone. So we've got staph, strep, atypicals, negatives, positives. It's got a great range of coverage, but it's got a high side effect profile. It can cause tendon damage, CNS symptoms, neuropathy. A major issue is tendon rupture, especially the Achilles. And the risk of this increases with age, renal insufficiency, and steroid use. And unfortunately, the patients who are very ill and would more likely need levofloxacin are typically older and might have comorbidities with renal insufficiency, might be using steroids. So we want to be overly cautious with that. We also want to avoid giving fluoroquinolones to people with connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome. All of these side effects you can see kind of target the tendon damage, targets connective tissue. So if you have a patient with a connective tissue disorder, giving them a quinolone can temporarily or permanently cause some damage in a patient who already has a connective tissue issue. So keep that in mind as well. I even put it on their allergy list if they have Marfan's or EDS, just to go ahead and make sure, even if they come into the ER completely comatose and out of it, people try to pick something else other than a quinolone first, with a note of why. Next class is your tetracyclines, which includes doxycycline and tetracycline, and here we typically only use doxycycline. Doxycycline is used for Lyme, RMSF. We also use it as an alternative if patients are allergic to penicillins and cephalosporins. You can use macrolides in a similar way as far as an alternative to those who are allergic to penicillins and cephalosporins. But again, the macrolides seem to have some resistancy issues. So cautiously use doxycycline so that we don't get resistancy issues there. But it is helpful as an alternative for those things like sinusitis and community-acquired pneumonia. We can also use it to treat syphilis if they're allergic to penicillin, and it can be used for malaria prophylaxis, very cheap way to do malaria prophylaxis if someone is going to an endemic region who needs that prophylactic treatment. We don't use tetracycline on children under the age of 8. But again, generally we don't use tetracycline, so this is not going to be a large concern. It was previously thought that doxycycline also caused permanent tooth discoloration, but after years of meta-analysis and study, there is no evidence that doxycycline causes tooth discoloration, and so we can use that in children. Pregnant women should not be given tetracyclines because it is a category D. It affects skeletal malformation, so we want to avoid that one in pregnancy entirely. And then tetracycline is rarely used. Next is clindamycin. Don't get this one confused with your macrolides. This one is a standalone, kind of its own person. Clindamycin is used for various different issues. It is used for skin and soft tissue infections. We can often use it alongside of a cephalosporin. We're going to use it by mouth for MRSA, but it's not the best. It's not the first line option. It is an option. A very common use that I find in primary care is using it topically for acne as an ointment or cream. It can be used intravaginally for bacterial vaginosis. And if you're working in the ER as a nurse practitioner, you can use it for toxic shock syndrome. One of the main things you need to look out for by mouth clindamycin or IV clindamycin is that it can cause C. diff. It is a high risk for C. diff comparatively to other antibiotics. So that is a concern. Flagyl, I always say F for your funky stuff. Flagyl, funky. We're going to use it for B, C. diff, H. pylori, parasites, trichomoniasis. So kind of your funky guys there. One of your main kind of high yield questions on boards is make sure that you don't let them consume alcohol while using it and for 14 days after treatment. And it is safe in pregnancy. So you can use it in a pregnant patient if they are experiencing bacterial vaginosis, C. diff, something like this. So parasites, trich, BV, C. diff, all the strange things, F for funky. Bactrim. So Bactrim is a combination of trimethoprim and sulfathimexazole. So it is a sulfa drug. There are a lot of patients who are allergic to sulfas, and so therefore they'll also be allergic to Bactrim. It covers a majority of our respiratory tract pathogens. It covers a lot of the UTIs. It also covers salmonella. It can be used for prostatitis if it's a more mild prostatitis, shigellosis. That pneumonia listed there is the pneumonia that we find in our HIV patients. And then MRSA as well. This one covers MRSA. Bactrim is a very good option for MRSA, but vancomycin is also a very good option for MRSA. So you have two options there for MRSA. It concentrates well in the prostate and the vaginal fluids, more so than other drugs, which is one of the reasons we can use it for prostatitis if it's more on the mild side or not shocky. So there are new concerns with resistance with E. coli and certain pneumococci. So that's why it's still used very frequently for UTI, but I still prefer macrobid, which we'll discuss at the end of the antibiotic section, for UTI over Bactrim. So there's some interesting side effects too with Bactrim. You've got blood dyscrasias, some pretty intense nausea and vomiting, and drug fever. With the nausea and vomiting, if you use the extended release version of Bactrim, the side effects there can be mitigated or decreased. So there's an extended release version of Bactrim. Anytime you get something like that, it's usually a little bit more expensive for the patient, so be cautious in doing that. And then lastly, macrobid, it's only used for UTIs because it collects in the urinary tract system very well. It can be used for long-term prophylaxis. There's very little resistance. Do not use if they're between 38 to 42 weeks pregnant or if they've got a G6PD deficiency. I do recommend that patients take this one with food. It can cause quite a bit of nausea and food aversion. But do make sure that they take it with food to kind of mitigate that. And then it is contraindicated in patients with renal failure. Any questions there before we go on to our next section of hypertension? All right, so let's talk about hypertension. So this is one of our most common issues, right? I mean, I am in home health with geriatric patients, and basically everyone has high blood pressure. I think maybe one patient in the last couple of weeks didn't have high blood pressure, but most people do, either whether it's very mild, it responds to one medication. I saw someone yesterday who was on maybe 4 or 5 different medications to help treat her atrial fibrillation and her hypertension, and it was so many medications all at once. And she was feeling very tired and weakened by all of that too, so we had a long discussion about the medications that she was on, what could be done about this, if she was experiencing orthostatic hypotension, just going through lots of things with her because she was on so many medications trying to get her blood pressure under control. So what kind of symptoms do they have? It is called the silent killer. They're often asymptomatic, and that's when I find it really difficult to convince patients. I had another patient last week who was very hesitant to discuss more medication, more blood pressure medication, even though her blood pressure was quite high. She said, I would feel something, right, if it was too high for me. And we just kind of talked about that it is a silent killer. It does damage when it's that high. And I understood her hesitancy in taking another pill, but the benefits for me outweigh the risks. And I love to tell patients they don't have to take this medicine or that medicine or things like this. But I really recommended for her that we were able to, kind of bump up some of her doses, start a new medication. So if they did have symptoms, we see things like a throbbing headache, dizziness, visual changes, but again, it's often asymptomatic. The risk factors associated would be age, family history, diet, exercise, alcohol, smoking, genetics. What kind of things cause this? Most patients have a primary or essential hypertension, which means if it's a primary issue, the issue is kind of the issue itself. Secondary means there's another organ or system or problem going on that's causing the hypertension, like kidney disease or hormonal disorder. That's much less common. Primary or essential hypertension is definitely the most common type, and it runs in families, so you'll see people who seem otherwise healthy who have high blood pressure. Maybe they have a couple of risk factors. Diagnostics, we use AHA. For treatment, we use JNC8. We'll talk about those more in a moment. For labs, it's not a one-size-fits-all, so I can't tell you do this, 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 and this. So you need to assess the kidney function very frequently, especially with some of these blood pressure medications, which can affect it. Also, high blood pressure does damage the kidneys over time if it's not well controlled. We also need to check for cholesterol levels and diabetes. Sometimes, if it's more of a diet thing or a general state of unhealth, they might have cholesterol issues, diabetes, things like this. Also, check a urinalysis at regular intervals to see that also can help assess the kidney function. But again, it's not one size fits all. It's not exactly the same for every patient that comes in the door. What are our blood pressure guidelines right now? So right now we want to see it less than 120/80. That is kind of a new thing. I was working in cardiology as a nurse in outpatient cardiology when this started being discussed about dropping the normal, so to speak, down even lower. And a lot of the cardiologists didn't feel like they were seeing a lot of benefit from that because they were saying, no, 130, less than 130 is sufficient. And so I still kind of keep that in the back of my mind that less than 130 is still sufficient. That's what I'm looking for. So now we call elevated between 120 and 129 with the diastolic still less than 80. Stage 1 is what we used to call pre-hypertension, and this is when it's 130 to 139 or the diastolic between 80 and 89. And then lastly, stage 2, which is hypertension, systolic at least 140 or diastolic at least 90. Then the big reason they wanted to make these changes is instead of calling this pre-hypertension, they wanted to call it stage 1, because for those who are in stage 1 and have had a major cardiac event, you can consider giving them a low dose of an antihypertensive if they've had a major cardiac event, if their blood pressure is elevated but not truly high. What do we define as a hypertensive crisis? That would be systolic blood pressure of 180 or diastolic over 120. This was kind of the biggest change I had to make when working in primary care. If there are no indications of problems or end organ damage at the visit and they just have high blood pressure and it can be 180 over 100, you need to check it a few times. You need to be very thorough in your assessment to make sure they're not about to have a stroke, they're not dizzy, no new headaches, no vision changes, no signs of end organ damage. At that time, you need to do a prompt change in their medication. You need to tell them, all right, when you get home, you're taking another dose of the medication you're already prescribing, and then we're doubling your dose and adding another medication. Please pick this up, take it today. Let's start getting your blood pressure under control. If they are having vision changes, stroke-like symptoms, anything like this, we immediately need to hospitalize those patients. Acute kidney injury, acute kidney failure, looking for all those things if blood pressure is that high. Okay, we need to make sure that we chart very thoroughly. Most charting systems and most like HEDIS measurements or auditors, if you have an auditor within your system, are going to send back lots of notes and comments on your chart if you do not explain very, very, very in detail why you sent somebody with a blood pressure of 180 over 100 back home. You need to be very thorough and detailed because that is high risk for somebody having a stroke or a major event. We need to make sure that we chart very well, that they were educated, no signs and symptoms of immediate issues, lots of things discussed. Because if you send them to the ER, they're just going to do the same thing. They're just going to change their medication. If there's a medical emergency, send them to the ER. If not, promptly change their medication, get them to take an extra dose of whatever they're currently prescribed when they get home, tell them to start a new medication immediately. So that's kind of the game plan there. And so that was kind of a big change from working as an ER in the hospital setting to working in the outpatient setting. Because in the hospital, we want to keep really tight parameters over everything. So we would be running down the hall with a labetalol if it even hit like 160, right? So it's a bit of a change. I commonly see patients with blood pressure 160 on top, even on medication. Make sure you're allowing your patients ample time to sit and rest before you take their blood pressure. 5 minutes is barely enough. If you look at some of the most recent studies coming out, blood pressure decreases more and more the longer we let them sit. So if we take it as soon as they hit the door, it's going to be elevated. If we let them wait 5 minutes, it might still be falsely elevated just due to them moving around, okay? So the longer you allow the patient to sit before you take their blood pressure, the better. Currently, where I am, I wait until almost the end of my visit to take their blood pressure. I do all of my HPI questions, things like that. I do all of that first to make sure they sat for as long as possible before I take their blood pressure. So that's been helpful, and to try to get the most accurate blood pressures that I can. So what are our guidelines? What do we consider for treatment? So if they're younger than 60, we will start treatment at 140 over 90. If you're over the age of 60, we'll start treatment at 150 over 90 because we want that blood pressure to rise up a little bit more before we start medications. And do you guys know why? Put that in the comments. Why do we let the blood pressure rise to 150 over 90 before starting treatment for patients older than 60? And lastly, if they have chronic kidney disease or diabetes, even if they're over the age of 60, we still have them start medications at 140 over 90 because they're more likely to get lots of kidney damage, and we want to protect the kidneys as much as we can. Here's some of the options for our medications. You can kind of go down this flow chart. You can take a look at that later. You can pause here and kind of peruse that. But I want you to kind of notice one thing. A lot of students ask me, "Oh, what do I do? Where do I start? How do I titrate? How do I know when to go to the next medication?" Because there are lots of different ways that we can do this, how to titrate the strategies. It gives us 3 options at the bottom here. We can either maximize the first medication. So if we start with lisinopril, which is a very common first line, if we start with lisinopril, we could raise it all the way up to 40 milligrams before adding a second. But a lot of patients will benefit from 2 different ones because they work in 2 different parts of the body when you start to add different drug classes. And they can work synergistically to bring that blood pressure down more effectively. So that would be the second method there is you could add a second medication before reaching the maximum dose of the first medication. So you start them on lisinopril, they come back to the next visit, the blood pressure is not under control. Instead of increasing the dose to the highest dose on that lisinopril up to 40, maybe you keep them at 20 and you add a 12.5 hydrochlorothiazide to see if treating it from a different angle at the same time is more effective. Lastly, you can start with 2 medications. And so that would be something like treating them with lisinopril and hydrochlorothiazide or amlodipine and hydrochlorothiazide on their first visit, which can definitely be prudent if somebody's blood pressure is 160, 170, they're having some kidney damage, things like this. And it looks like that would be a good idea for them, especially if there is kidney disease. We would want to lean more lisinopril to start off, and adding another medication like amlodipine or hydrochlorothiazide to make sure that we're immediately addressing the blood pressure and protecting the kidneys as best as we can. So those are your options. And I do tend to kind of go with method B, where I start them on a lisinopril and then have them come back in a couple of weeks to a month first of all, to check their labs, and second, to kind of look over their blood pressure log to see if we've made any difference. And at that point, I can go ahead and start hydrochlorothiazide. You can also pause here and look over this slide for side effects, notes, and considerations that I've thought about for some of the drug classes that we commonly prescribe. So with these blood pressure guidelines that I don't love, the point again of making a stage 1 of hypertension is if the patient's already had a heart attack, stroke, high risk, we can go ahead and start a low dose of blood pressure medication. Again, we don't want to be dropping them down to 90, 100 on top, because then they're going to get dizzy. Also, with the new blood pressure guidelines, there was a lot of emphasis on a need for 2 or more types of medications. And so that's why I've kind of shifted my method. Instead of increasing lisinopril all the way to 40, I try to start a second one. And then after I have 2, I will try to titrate those up all the way to get it to 40, maybe a 40-25, something like that on the lisinopril hydrochlorothiazide. So then once you find out if they're stable, if their dose is stable and we're not having to change it anymore, you can start ordering it as a combination pill. We love to decrease what we call pill burden. It's kind of a mental thing. They're taking less pills. It feels less difficult if they have to take, 1 pill instead of 2, especially if they're having to take a whole slew of pills. It's just helpful to decrease the actual physical number of pills going in their mouth, because then it's less of a mental burden too. So what are some other major guidelines, things to think about, rules when we're managing, diagnosing blood pressure? We don't really want to base it off of a single visit alone. We want to do it on 2 separate visits, 1 to 4 weeks apart. We want to do a chart review, go back and look at previous visits to see if they've had high blood pressure on multiple visits that weren't related to pain or an illness or something like that. And we can see this trend of high blood pressure that maybe hasn't been addressed yet. So we'll go ahead and initiate medication, or we'll have them come back in for a nurse visit. I also really encourage patients to take their blood pressure at home to rule out that white coat hypertension, which is, I guess I kind of believe in it, but I'm still really worried if they're that stressed and their blood pressure gets that high, how often is it getting that high due to a stressor? So I want them to take their blood pressure at home. I want them to take it in the morning when they wake up, after they've been sitting for 5 to 10 minutes with their feet flat on the ground, take their blood pressure. They can't talk while they're getting their blood pressure taken. Their feet need to be flat. And then keep that journal. If I've already put them on medication, I also like for them to take their blood pressure 3 hours after they've taken their pill. That's usually the peak of effectiveness of that medication. I want to know, how is it working at its peak? If their blood pressure is 160, does it bring it down to 120 at the peak or not? I want to know that information. So those are the 2 times a day I want them to take it. Some patients will also take it at night because they might start to get a headache or dizziness towards the end of the day as their medication kind of wears off. So sometimes we'll do split doses for patients if that's an issue. So it's tailored to the patient. It really is. We kind of have a systematic general first approach, and then we start to tailor it to the patient as needed. The older the patient, allow that blood pressure to rise. And here's why. I asked that question earlier. Because we're worried about orthostatic hypotension. Older patients are more likely to have a sudden drop in their blood pressure. So we want to let the blood pressure kind of run a little bit higher, because when it does drop, we don't want it to drop to 80 or 90. They stand up, pass out. And that drop occurs when they stand up, not while they're sitting. Then lastly, some more specific symptoms of hypertension crisis. Again, that's that 180 or 120. If they have any of these things, and you need to chart the absence of these if you're going to send them home. So chart the absence of nausea, vomiting, headache, papilledema if you can look, stroke-like symptoms, any signs of a PE, MI, or AAA dissection. You want to chart the absence of those if you're sending them home. If they have any symptoms of those things, it's a one-way ticket to the ER. Call 911, let them refuse if they don't want to go, and chart all of that. Thiazides are the diuretics of choice for blood pressure management, but if they are on something like Lasix or spironolactone for congestive heart failure, then you might not need as high of a dose of the thiazide or remove it altogether, because they do work a little bit differently, but we don't want to dehydrate the patient or drop the blood pressure too low. But we're not going to choose to give somebody Lasix unless they have edema and heart failure, not for hypertension alone. So let's review one more time the labs to monitor. We have to think about what organs are affected by high blood pressure. Kidneys are number 1. And so what are some of the things that we can check for kidneys? UA is a very cheap and easy screening method. You can do the protein dipstick, microalbuminuria can be sent out, check their BUN, creatinine, EGFR to help stage if they do have any kidney disease. You also want to measure their electrolytes. This will help you monitor side effects of medications as well as causes of hypertension. So we're going to look at potassium, sodium, calcium. Also, we find patients might have anemia of chronic disease when they have high blood pressure. It is more common with some other more inflammatory chronic conditions, but you can have an anemia of chronic disease with hypertension. So check their H&H, check an iron panel if you need to. Check lipid panel and triglycerides. Consider diagnostics for cardiomegaly to see if the heart's enlarged at all. Do an EKG, do a chest x-ray to see if you've got that enlarged heart. And there's also findings and changes on EKGs that correlate with cardiomegaly that you can also look for. That wraps up hypertension. So let's go to our last topic of the day, which is diabetes, another one of our big 5 chronic conditions that we commonly see. We'll talk about the other commonly occurring chronic conditions next Wednesday at 4 o'clock Eastern Standard Time. So we'll keep going with that. So let's talk about diabetes. What do they present with? We always ask these same questions: polyuria, polydipsia, polyphagia. We'll see that they might be fatigued, weak, slow wound healing, numbness or tingling in their feet, sudden weight loss, frequent urination, blurry vision, nausea, sometimes yeast infections as well, because if their sugars are out of control, yeast loves sugar. So it might grow and proliferate. Risk factors include a family history is a big deal. If you've got a first-degree relative with diabetes, you have an increased risk. And if you have any of the additional risk factors, it's even more likely for it to occur. And it's some lifestyle things like obesity, sedentary lifestyle, the history of a gestational diabetes as well. So if a patient had gestational diabetes while pregnant, we want to monitor them more frequently maybe than the average population for diabetes because they have a higher risk. Comorbid things like hypertension, dyslipidemia, these things commonly occur together. We want to monitor for signs of retinopathy, neuropathy, which is again that numbness and tingling in their hands or feet, nephropathy, looking at the kidneys. Diabetes is a microvascular condition. The sugar deposits in our tiny blood vessels, and so that's why it goes after the nerves, the eyes, the kidneys, and also it causes cardiovascular disease because all of those coronary arteries and all of your vessels, like thinking of peripheral artery disease, peripheral vascular disease, coronary artery disease, the sugars are going to land, collect, and aggregate in these small, tiny little vessels and cause damage because we're going to have, kind of long-term ischemia at low levels constantly, and it's going to cause damage to all of these areas. What are some of our diagnostic criteria? An A1C greater than 6.5. The fasting glucose is greater than 126, meaning they haven't had any intake for 8 hours prior. If we do a 2-hour oral glucose tolerance test of 75 grams of sugar, it's greater than 200 would be considered positive, meaning they take 75 grams of sugar. We check the blood sugar 2 hours later. We would want that sugar to have dropped back down below 200. If it stayed over 200, that would be diagnostic criteria. If they have symptoms or random blood glucose of over 200 at any time, we could also consider that diagnostic criteria. Any of these alone are diagnostic criteria for diabetes, but you always want to get an A1C before you start therapy because you want to have something to compare your treatment plan to. So you want to check that A1C again in about 3 months after you initiate treatment to make sure that that average blood sugar over the course of 3 months has significantly decreased. We want to test our asymptomatic adults age 45 and older every 3 years. I do find that most offices test pretty much everybody at least once a year, but we can wait until they're 45 and only do it every 3 years. We can test it less frequently. But if we have symptoms or risk factors, doing that annual testing is appropriate. Here's our glucocentric algorithm for glycemic control. You can take a look at this later to kind of go through here and see what the preferred, the alternatives, or the concerns are. Generally, we just don't like sulfas. Sulfas are not our friends at this point. But if they're overweight or obese, we do like to use the glipizides, the new medications that are very common right now, like semaglutide, tirzepatide, to help bring down the weight, which also typically brings down the sugar. It also has cardiac protection, so it's got a lot of good things all at once. And so you can kind of look down through here and see some of the different benefits of what kind of issue they have as far as what is our preferred treatment. And this is a great algorithm. This can be found with the AACE as far as, again, the preferred treatments. So first line, we pretty much put a lot of patients on metformin. That's a very affordable. It's been used for a long time. It is one of our first line options. We, of course, also like to use things like the Tides, the Ozempic and things like this. So with metformin, one of the main things that we need to monitor for is renal disease. It is good for weight loss. It does have a low risk of hypoglycemia. We do need to hold it for 48 hours after IV contrast if they have a lower eGFR. And we need to, if they use it for over 4 years, we actually need to start looking at their B12 levels. Metformin alters the absorption of B12, and after about 4 years of use, the body can start to become a bit deplete, and we might need to use B12 supplements. And a B12 deficiency often looks like numbness and tingling of the hands and feet, which could be misattributed to as signs of poorly controlled diabetes. But don't let that confuse you. Make sure you're checking their B12 levels if they've been on metformin for 4 years or more, because it might not be diabetic neuropathy. It might be a B12 deficiency. So make sure you're looking into that. The GLP-1s stimulate insulin production in response to increased plasma glucose. They're good for weight loss. They can be used with or without type 2 diabetes. Our SGLTs are helpful as well. They end in gliflozin. This is things like Invokana, Farxiga, Jardiance. They do decrease the blood sugar by putting it out in the urine. The glucose will be positive on their dipstick. That's not a bad finding, so to speak. That's what's expected. It's an oral medication, promotes weight loss, low risk of hypoglycemia, but it does increase the risk of yeast and UTIs. If the patient has overactive bladder, urgency, things like that, this might not be the best medication for them. Next, we have our gliptins like Januvia and Onglyza, and these increase the levels of incretin, increase synthesis and release of insulin from beta cells. So this one does require a functioning pancreas because we need something to stimulate. So we can't have a significant amount of damage to the pancreas for this medication to work. If you don't really see a change after starting a gliptin, it just means there's not enough beta cells left to push to increase. So you might need to use a different medication that doesn't necessarily stimulate the pancreas. It works in a different way, something like an SGLT. With this one too, there is risk of lowering the blood sugar hypoglycemia because you do stimulate insulin. Next, we have these are our not as preferred. The slide before, more preferred. This slide, less preferred. So TZDs or glitazones, as they can be called either way, they decrease insulin resistance, increase insulin sensitivity, increase glucose uptake, but they do not put the patient at risk for hypoglycemia. It's more about the insulin sensitivity. So what we have there becomes more sensitive, but it cannot be given to those with heart failure. So we want to avoid giving these to patients with, severe heart disease or heart failure. The AGIs, we basically don't use these. They cause a lot of side effects in the GI tract. It does delay absorption of glucose in the stomach and the GI tract. So sugar is not absorbed as readily, but you have a lot of diarrhea, lots of flatulence is a big concern. So lots of stomach problems with the side effect profile there. And then lastly, the sulfonylureas, which were the standard go-to. It was like metformin, sulfonylurea, because it was affordable. It had been around forever. We didn't have a lot of these new drug classes, even 15, 20 years ago. And so sulfonylureas were the go-to, like glipizide or glyburide, but they have a risk for hypoglycemia. They can cause weight gain. And it's now on the Beers criteria list for geriatric patients to avoid because of the increased risk with hypoglycemia in that patient population over the general population. So sulfonylureas are not preferred generally, and then especially not preferred in our aging population. So if you have patients who have been on sulfonylureas for many years, back when they were more popular, it hasn't ever been changed, make sure you're talking about signs and symptoms of hypoglycemia or considering describing that medication for an alternative. This is an interesting chart that you can look at too that talks about the profiles of anti-hyperglycemic medications. This was also released by AACE, and it's got a list about the efficacy, so you can see that how well does it work, how strong is it in actually affecting blood sugar. And so you'll see metformin gets a 2, the GLPs get a 3, insulin you can push, right? Because insulin you can get tight control if you need to. And then, hey, how does it help well with kidneys? Does it decrease heart failure? Is it good with stroke? So what kind of things can we use it with? What kind of risk factors? Should we use it? Does it benefit us as blue? Orange is use it with caution. Red means there's probably not going to go well. So this is a very interesting and helpful chart as well that you can review. So let's talk about insulin. When do we need insulin? Sometimes we need it when there's a new diagnosis of type 2 diabetes, especially if glucose is 250 to 300 on the diagnosis. If there's insulin resistance that's quite severe, we're on more than 2 oral anti-diabetic medications, we're not seeing a change. It just means that the pancreas is so far gone at that point that we do not have enough beta cells left to do anything with. There's not going to be anything done that we can really do with these by-mouth medications, so that we're going to need to start them on insulin. If there is an acute illness or a hospitalization, you need to start with basal. And then if there's acute illness or hospitalization, they might need a short-term time when they're on insulin because sugars rise when we're acutely ill or hospitalized. There's often stressors or illnesses, and all of that, the cortisol levels increase, the sugars increase. Sometimes if they're in the hospital, they've got a respiratory problem, they're on steroids, their sugars increase, and bacteria love sugar. So we want to keep a very tight control on their sugars while they're sick to help them recover more quickly, and then maybe we can come back off of that insulin. If you're going to start a patient on insulin in the outpatient setting, you're going to start with basal. Basal is the long-acting. This covers them all day. This acts like their pancreas. So we're replacing the pancreas. We're going to use Lantus. Levemir was discontinued towards the end throughout 2024. So now we're on Lantus. Bolus, if you need to do something bolus with the meals, this is what our body would normally do. We eat food, our insulin levels increase to get our sugars stable. So we're going to replace that if we need to as well. We can start with basal and then add bolus if we need to. So short, intermediate, things like Lispro, regular, NPH. If the postprandial sugars are high, so they eat and then their sugars are quite high, we need to increase their bolus. If their fasting sugar is high in the morning, we need to increase their basal most of the time. Okay. Other times we might have a morning hyperglycemia. Sorry, a little cough there. Sorry if I have to pause again. So most of the time, if the fasting sugar is high in the morning, we would expect that we just don't have enough insulin, right? But every now and then we actually have something called the Samoyed effect, which is we actually are giving the patient too much insulin. And this is very interesting. So their nighttime dose might be too high. So their blood sugar actually crashes in the middle of the night while they're asleep. And so the body dumps excessive amounts of sugar to kind of make up for that, right? And so they wake up in the morning and the sugar looks high. This is more on the rarer side. Most of the time it's we don't have enough insulin covering us, and so we need to increase the dose. So what we do is we have them, they can do a monitor, they can do just waking up and taking their blood sugar in the middle of the night. Sometimes they'll wake up in a cold sweat because their sugar is kind of low, that we want them to take their sugar. And so that can kind of help us diagnose between those two things to let us know if it's the Samoyed effect or more of a dawn phenomenon, or just the morning sugars are high, we need to increase the dose. So those are the differences between the two. With the advent of the monitors, it's become much easier to determine which of these two things are going on. So we can decide if we need to decrease or increase our insulin. So lastly, just some care tips, some other things that we might need to do alongside of diabetes is checking their cholesterol annually, their creatinine at least annually, doing a yearly microalbumin. and glucose. Again, A1C every 3 months if new, or you've needed to change their medications every 6 months if they're stable. For education, we need diet education. Got lots of education here. My diabetic patients always think fruit is safe. They're like, it's fresh, it's healthy. I have had so many diabetic patients just over consuming fruit to replace carbohydrates. But that is still a sugar and it will still cause problems if they're overeating fruits. Diabetic educator if possible, encouraging exercise, encouraging dental care, and a yearly dilated eye exam to check for diabetic retinopathy. And always, always look at their feet if you can. At each diabetic follow-up visit, you're looking at the bottom of their feet, between their toes, looking for non-healing areas, looking for places if they have numbness, tingling, how the nails look, do they need foot care, podiatry, kind of looking over all of that to make sure that they don't need some sort of intervention, wound care specialist, hyperbaric chamber, things like that to prevent the need for amputations, which are very common in those who have uncontrolled diabetes and peripheral neuropathy because they can't feel the wound developing. So that's why we want to look at the feet as often as we can. So if you want to get the full kind of review course, the Expert FNP review course, this is the course that you can sign up for. So January is closed, but the Expert FNP review course for February, the registration for that is open, and I believe that is the weekend of the early 20s, maybe 20, 21, 22. And so if you want that link, I can go ahead and put that in the chats on both YouTube and here if you would like to register for the full course. So if you want to register for that full course, there you go there. If not, I'll see you next week, Wednesday at 4 p.m. Eastern Standard Time, and we'll keep going over a few more of what we call the Big 5 chronic conditions. So I look forward to seeing you next time. I'll stick around for a few minutes if anyone wants to ask me any questions or anything like that. Thank you for joining me today. You're absolutely welcome, Tanita. All right, see you next week. Bye-bye.